Hey, Vlad. Is that you, Vlad?
John, hello.
Hey, Vlad. How you doing?
I'm doing fine. What about you?
You must be bored.
No, I'm not, but we are locked down. But yesterday it's better because we started to have some sports. So I played tennis the whole evening.
Oh, you play tennis?
Yeah.
Oh, wow. I used to play a
after
lot.
6 weeks, some movement, something, you know, it's really boring. But you must be exhausted. 3 webinars a day or 4?
Good. Good for you. Hey,
no, good for you. You are having a lot.
Well, you know, we had Benko on yesterday.
I see.
Benko came to Juha's.
I saw the advertisement. I didn't have time because I played the tennis, of course.
Yeah, he's talking next week. Yeah, he's talking at Juha's next week.
Must have been great. Yasargil was excellent. With
yeah, well, you know, Juha does something that's very smart. At first I thought, you know, you should have the speaker there speaking. But what he does is he has them send a video that they made, probably the same day, and he sends a video, and it works great.
It does.
Yeah, you know what I mean?
It was excellent.
Yeah, so the speaker doesn't have to come to the conference, but it's done the same day or just before.
I see.
Because they say, well, hello in China, like Ali Krish said, hello in China. You know what I mean? He addressed the audience. So it was specially made for them. So he knows, you know, that it's
Do you at all leave the chair in which you are sitting, or are you sitting there all the time? Because you must be so busy.
No, this is fun, you know, but the hours are crazy. You know, the hours are crazy. I get mixed up all the time with the hours, but the times change sometimes. That fool Spetzler, we were in a room waiting for him, wondering, where is he? We had 100 people. And he came late because the hour difference. He's in Arizona, which is like 4:35 at 30 in the morning. But China, there was a time change. I didn't know about it either. It fooled me. And so he assumed it was the old time, but it wasn't. It was the new.
It was nice what he was saying. You know, the video as he was leaving after his last surgery, it was really moving.
Yeah.
I spent a year with him, so he's one of my teachers. You know.
Who'd you spend the year with?
With Spetzler.
In
Phoenix, Arizona.
Oh, a year there.
Many years ago.
Oh,
he
wow.
was young as me too. At the time.
Was Barrows there yet, or did he start Barrows? It was there. Barrows was
there. 88, 89. I was there, and he was at Barrow for say something like 4 or 5 years.
Oh, so Barrows was there then at that time.
Yeah, of course, of course.
Okay.
There was the guy named Green who started Barrow in the late 50s, early 60s, something like that.
Oh, okay.
And, he just got retired and Spetzler substituted him. The same as Lawton now with Spetzler.
Yeah. Well, Lawton's, I'm sure, will do a great job.
Yeah, great job.
Good teacher.
Yeah, he's very technical, so people admire him. You know, the young people, they are technical and they loved it always.
Oh, good. He is a very. It looks great in Arizona, hiking in the Grand Canyon. You must have went hiking there and everything, right?
Yeah. He was at the time when I was there, he was very hesitating because he was offered San Francisco, which is top probably.
Right.
In San Francisco, there was a guy named Charles Wilson, and he was one of his teachers, you know, and he really admired the guy very much, and it was like an icon for Spetzler, this guy. So he was hesitating for half a year whether to move to San Francisco or whether to stay in Phoenix. And then he decided to stay because at the time his parents were living them in some condominium for retired people.
Oh,
So that
okay.
was probably one of the reasons that he stayed in Phoenix.
Oh, okay. Okay. Yeah, Phoenix is off the beaten track, kind of. San Francisco, LA.
Yeah, it sounds better than Phoenix, of course.
Yeah. Yeah, it's but I don't know with internet now you can
It
make
doesn't matter.
Arizona. It doesn't matter.
It doesn't matter.
No. So it's getting less and
No,
less
it matters
important.
for your life. You know, if you Spencer was rather cultural guy, and in Phoenix at the time, 2 million city, and there was not a single theater. You know, nothing like that. So it was a boring city if you were interested in other things but medicine.
Oh yeah. Like Boston's good for that culturally.
Yeah, it's a good
Boston, if you're really into the culture, because America is not a culture, too cultural
Well, if you are in
country.
culture, then you must
Our
go to
culture
Europe.
is McDonald's.
Exactly.
So Miami's that way too.
Yeah,
It's the same thing.
that must be. That must be. I've been there once only, and it's too big.
Well, someone said to me, he says, John, the people in Florida, they just need a couple more years of school.
Where from are you
And I had to
originally?
agree with him.
Where from are you originally, John?
Boston, around, it's just
Boston.
just south of Boston.
I see.
I don't miss the cold weather. I thought I would, because I grew up like you in the cold weather. I thought I'd really miss it, but I don't.
No.
Especially once I was here for a couple of years and I
Yeah.
tried to go back. Oh man, I said, man, I don't need this. I want to wear shorts.
Yeah, that's what we now have. It's like the temperatures are around freezing point. The days are short. So this is the worst time of the year.
Yeah, really?
Yeah, the short days, cold weather, rain or snow, and everything's
Well,
like
where do you
very
said you play
depressing.
tennis? You play
What?
tennis? You play tennis today? You said
Indoors.
Oh, indoors. Oh, okay.
Indoors.
Yeah, I was wondering.
It's impossible outside. Impossible.
Right. Well, indoors is like all the same all the time.
Just okay. John, I'm going to make coffee for me before we.
Yeah. Okay. I'll be here.
I'll switch myself.
Okay, I'll be here.
John?
Yes, yes. Vlad, can you hear me?
It should be in 2 minutes and there is nobody there.
Hold on, hold on. What's that, Vlad?
Yeah. It should be start. We should start in 2 minutes or
Yeah, well, one of the speakers is having a hard time.
no.
Last minute technical issues with him, and he's a
Nice.
speaker.
Okay, so I should switch myself off again.
Yeah, hold on. Yeah, we got a couple minutes left.
Yeah, hello.
Hello, good morning.
Good morning. Good evening for us. Thanks.
Good evening. Do you know Vlad? You know Vlad Bennett?
Yeah. Hello. How are you? Benes,
Vlad.
how are you?
Hello.
Hello, how are you?
How are you?
Thank you.
Yeah, I was surprised to see Vlad. I'm honored, obviously, but it's great to see. It's like Elvis coming to your concert. Hey, is that Ankit here? Is he here? He's gonna moderate, I think. Ankit, are you here? No, possibly not. Okay, we'll just wait a few minutes. Oh, here he is. Here he is. Hi, Ankit. Can you hear me okay?
Yeah, I can hear you.
Oh, how you doing?
I'm having problem logging to my laptop. I'm doing good.
Yeah.
How are you doing?
Okay. Okay, the problem is with on his end. It's not on our end. Okay, he's got to reboot the computer and make sure he has the right link. He may be trying in the wrong link. Okay, Ankit. Hello, can you hear me, Ankit? I'm gonna give the link. Oh, there you are. You got in.
Yeah, I've just gotten through my iPad. However,
Okay.
I'm not able to get in through my laptop.
Okay. Okay, Ankit is going to moderate, right? Right, Dr. Chetta?
Yes, just give me a minute.
Okay,
I'll be there in a minute.
okay. There's no hurry. Oh, there you are. Hello, Ankit. Wow, you're moderating from the street. That's great. That's okay.
Hello. Hello. Good evening, sir.
Yeah, good.
Can you hear
Ankit, nice to meet you. Yeah, I can hear you very good. Very
Yes,
good.
sir. Hello, sir.
Okay, yeah, I'm Dr. Bennett. And we are honored with one of the legends of neurosurgery, Vlad Bennett is here today. But we'll introduce him before. Okay, Ankit, you're basically gonna run the show, right? You're gonna run it?
Yes, sir.
Okay, so that means, you know, when the speaker's done, you moderate the questions, and I guess Dr. Cheddar, you can help there too, right? And you basically make it go.
I've gotten a message from one of my chairperson that it's showing as an invalid link.
Okay, what's that? He's having a problem getting in?
Yeah, he's having problem getting in.
Okay,
Dr.
well, he has to
Mishra?
figure it. Okay, he's got to figure it out. Everyone else is coming in fine. Okay, we're ready to start. Okay, I'm going to introduce you first, Dr. Ankit, and then you just run the show, okay?
Yes, sir.
You're the boss. Ankit, you're the boss, okay?
Yes, sir. Yes.
Okay, 10, 9, 8, 7.
Be
Hold on.
introducing
No,
the chair.
hold on, Ankit. Hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. We have the residence log today, and Dr. Ankit is going to moderate and he'll tell you what's going to happen. Good day, Dr. Ankit.
Good
Ankit,
evening, sir.
Go ahead, Ankit.
Yeah, Rishabh.
Go ahead.
just wait for a minute. Mishra sir will be joining.
Hello.
Just give him a minute. Yeah.
No, we're going to start now. Okay, Dr. Ankit, go ahead.
Yes, sir.
Uh,
Yeah, good
you-
evening,
you-
everyone.
Okay, go ahead.
Today, we are here for the second episode. Hello.
Okay,
Yeah,
we can,
Ankit, you
we-
can go ahead. Sir
okay,
has
we
already
can always
joined.
Hello.
edit this out. Don't worry. Okay,
Yeah.
okay. 10. You ready to start, Dr. Ankit? You
Good
ready?
evening.
Oh, wait. Boy, this is a mess. Hold
Yes,
on.
sir. Yes, sir, I'm ready.
Okay. Well, okay. Start when you want to start. Okay. Okay.
Okay, sir. Sure.
Good. Okay.
Yeah,
I like.
good evening,
Okay.
everyone.
Let's wait for Dr. Mishra.
Yeah. Wow, this is a mess. Hold on. Hi, this is Dr. John Bennett, broadcasting from Miami Beach. We have the residence log, and the moderator is Dr. Ankit. He's going to explain what we're going to do, and he's going to moderate. Good morning, Dr. Ankit.
Morning, sir.
Go ahead. Go ahead.
Hello. Good evening, everyone.
Okay, onward. Okay, Ankit, what's going to happen today? Dr. Ankit, are you there?
Good evening, everyone. Yeah, I'm here. Can you hear me?
Okay, yes, we can't see you.
There are some issues. Hello.
Okay, well,
Ankit,
Dr. Chetta, perhaps you'll take over.
Yeah. So I'm sorry for the goof up, technical error basically. Yeah, there he is. I think he was trying to share a screen. So Ankit, if you could just go on to the slides and introduce our.
Yeah, can you see my screen, everyone? Yeah, can you see my screen?
Yes.
Yes, we can.
Good evening, everyone. Today we are here for the second episode of the Residence Log 2021, and today we will be discussing and approach to a case of a CP angle SOL. Today we have two very prominent neurosurgeons with us who will be chairing this whole discussion. Good evening, Professor Dr. B.K. Mishra, sir. He is currently the head Department of Neurosurgery and Gamma Knife Radiosurgery and the Chief of Surgery in the PD Hinduja Hospital and MRC since 1995 in Mumbai. He was also a clinical professor, Department of Neurosurgery in Macquarie University, New South Wales, Australia from 2012 to 2014. Under his guidance, PD Hinduja Hospital and MRC was the first hospital in South Asia to acquire the Gamma Knife technology. He was also the first in South Asia to perform the Gamma Knife radiosurgery. He was the first surgeon in the world to perform computer-guided aneurysm surgery. Dr. Mishra was also the first in India to perform an awake craniotomy. His expertise in neurosurgical patient care include acoustic neuroma surgery, vascular neurosurgery, skull-based surgery, pituitary surgery, gamma knife radiosurgery, awake craniotomy, minimally invasive neurosurgery, and complex brain and spine disorder. He was recognized as one of the world's top neurosurgeons, which was published in the Jolie magazine, the world's top neurosurgeon 16 that matter. Our second chairperson is Dr. Professor Sanjay Bihari, sir. Good evening, sir. He is currently the professor and head Department of Neurosurgery in Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. He has done in fellowships from Sugita and Fujita International Fellowship in Japan, UICC Fellowship in Germany and Switzerland, Commonwealth Fellowship in UK, and Dartmouth Fellowship in USA. Apart from that, he is also in the editorial board in Acta Neurochirurgica, Neurology India, Journal of CV Junction and Spine, and others. His areas of interest include the skull base and neuro-oncology, complex spine and CV junction, and vascular neurosurgery. He is also a National Executive Committee member in the Dandy International Neurosurgical Society, NSI, AO Spine International, Indo-German Micro Neurosurgery Skill Training Program, Indo Society for Cerebrovascular Surgery. Apart from that, he is an avid teacher. He is an MCH and DMBA examiner in 22 national university and PG institutes, 9 intramural projects, 3 international projects, guided 8 MD and 9 PhD cases. Today, we have Dr. Rushabh Chheda. He is currently the registrar in LTMG Sion Hospital in the neurosurgical department. He will be presenting a case on a CP angle as well. Over to you, Rushabh.
Thank you very much, Ankit. Before I proceed, I would like if any of the professors sharing the session would like to comment before we can start our session today. Professor Mishra sir or Professor Bihari sir, if they would like to comment.
No, I think this Sanjay, you want to speak? I mean, they supposed to. I was told he's going to present, and then you are going to assess him. Is that the format? That's what Rishabh told me. So please go ahead.
Yes,
I have
yes,
nothing to comment. We will comment afterwards. Sanjay, Dr. Bihari can comment, I think.
Okay.
We are very honored to be here, and this is a very nice forum for everybody to learn. We need to learn as much as you do. So please, let's go on.
Thanks a lot, sir. Thank you very much. So without wasting much of the time, I think I'll start with my case presentation for today. So I'll be presenting a case on a cranial SOL today. So my patient, Mr. Vilas Salgaonkar, 62-year-old male patient, resident of Mumbai, Hindu by religion, Marathi-speaking person, educated till 10th standard, right-handed person, was a mechanic by occupation, however, has retired since a year. The informant was the patient himself, along with his wife. My patient came with the chief complaints of decreased hearing in right ear since 2 months, difficulty in walking with a tendency to fall to the right since 1.5 months, decreased sensation on the right side of the face since 1 month, decreased perception of taste since 15 days, and headache since 10 to 15 days. My patient was apparently all right 2 months back when he noticed a decreased perception of sound in the right ear, which was insidious in onset and gradually progressive to the current state of not able to hear from the right ear, which forces him to try make him use his left ear to hear while in a conversation or use a phone. He also notices difficulty in hearing sound of a ringing mobile phone. He complains that he has to speak loudly and also has to able to listen better when he is also able to listen better when the patient is in a quiet environment and is face to face with the other person. He did not give any history of misinterpretation of words or difficulty in understanding a spoken word. He also does not give any history of earache, discharge, trauma, tinnitus, dizziness, any vesicular eruption over the ear, earache. No history of exposure to loud sounds or abnormal increase in the loudness of sound. No history of exposure to metals or toxins or long-term medications like aminoglycosides or antimalarials or antihypertensives. No history of similar hearing deficit in family members. No history of fluctuating hearing loss or fullness of ears. He complains of difficulty in walking with a tendency to fall on the right side since 1.5 months. The patient complains of difficulty to walk with a tendency to fall on the right side, which was increased by doing daily walks in the evening. However, patient does not give any history of worsening of walking in dark or on uneven surfaces. The difficulty is also not associated with any feeling of tightness in the limbs or weakness, and there is no diurnal variation in his gait. He complains of a reduced sensation on the right side of the face since 1 month, which was insidious in onset and gradually progressive. Initially noticed on washing his face when he complained of heavy and thick skin over the right side of the face. However, he does not complain of any pain, electric-like sensation, or difficulty in chewing. There is no history of redness of eyes, no history of decreased sensation over any other parts of the body. He also complains of decreased perception of taste since last 15 days, which was initially noticed for spicy foods, to the current state where he does not feel taste for any flavor of food. He also complains of accumulation of food on the right side of the face. There is a history of mild facial asymmetry, which was first noticed by his wife. There is no history of drooling of saliva from the angle of mouth, and no history of difficulty in closure of eyelids. The patient has also been complaining of headache since 10 to 15 days, which has been insidious in onset and gradually progressive. Fronto-occipital headache, which is non-radiating, mild in intensity, no diurnal variation or postural variations, aggravated by stress and relieved by rest and medications. The patient is a known myopic and has an history of change in spectacles 2 times in last 1 year. The headache is not associated with vomiting, nor nausea, or any visual deficit. There is no history of photophobia, visual, sensory aura, redness, or tearing of eyes. He also does not give any history of difficulty in swallowing, any nasal regurgitation, recessed and coughing while eating. There is no history of difficulty in shrugging of shoulders, raising of arm above the head, turning of neck, difficulty in tongue movements, deviation of protruded tongue to any one side. There is no history of blurring of vision or double vision or abnormal eye movements. There is no history of dark skin patches or any weakness in any of the limbs. The past history of the patient includes he was operated for a left-sided deviated nasal septum 40 years back, for which no documentation was available at present. Patient is a known hypertensive since last 10 years, which is controlled on medication on tablet amlodipine. A patient is vegetarian by diet, and there is no significant past or family history. So to summarize my history, I have a 62-year-old male patient with a gradually progressive decreased hearing in the right ear, which forces him to use his left ear and is able to hear better in a quiet environment. There's difficulty in walking with a tendency to fall on the right side without any diurnal variations. Decreased sensation on the right side of the face with a feeling of thick skin on the right side. There's decreased perception of taste with a mild facial asymmetry, and occipitofrontal headache which without any diurnal variation and without any association with vomiting. To conclude, I would say that my substrates involved on my general history taking would be the 8th nerve because of the decreased hearing, the 5th nerve because of decreased sensation on the right side of face, the 7th nerve because of decreased perception of taste, and cerebellum because of the tendency to fall on the right while walking without any diurnal variation. So the provisional diagnosis turns out to be a mass in the cerebellopontine region, cerebellopontine cistern, most probably, likely to be a vestibular schwannoma, seen at the age of the patient, and loss of hearing. The differentials would include meningioma, epidermoid, trigeminal schwannoma, or a CP angle abscess or a tubercular abscess. Should I continue with my presentation for the examination, or will be having a short set of questions, sir?
No. Sanjay, why don't you take over? Start asking.
Yeah. So, okay, sir. Can you stop sharing screen so that I can see you? Yeah. Hello.
Yes, sir. Yes,
can
sir.
you
Yes, sir.
stop sharing screen so that I can see you? Yeah. Nice one, Rishabh. I have a few questions for you. One of them was you said that hearing, that it was in quiet environment, and it was only could only hear in a quiet environment, and he could completely discriminate speech. So, what do you mean by saying that?
Sir, actually, I was trying to differentiate the loss of hearing, whether it is cochlear or retrocochlear, based on the history. since he does not complain of any difficulty in understanding words or any difficulty in discriminating words, which goes against the retrocochlear diagnosis of the retrocochlear diagnosis.
See, first of all, you have to discriminate between conductive hearing loss and sensory neural hearing loss. So the important thing, so cochlear and retrocochlear come later on. First is sensory neural versus conductive. So when would you say that a person has conductive hearing loss, and when would you say a person has unilateral sensory neural hearing loss?
Sir, the history which he gave, mainly of no history of trauma or any earwax.
Never start with no. Start with a positive thing. Don't start with a negative thing. Start with a positive thing. So what is it that you want to actually say? So one important thing is that if you put down buzzing noise and a person is not able to hear completely, then it points more towards the sensory neural hearing loss. You understand? Because a conductive hearing, that is number one. The second thing is that if there is, there are two things which are important. One is speech threshold and the second is speech discrimination. Speech threshold will mean at the threshold level which a normal person can hear, can this person actually perceive various sounds? And this is speech threshold is actually assessed by giving spondy words. Spondy words are, syllables. You understand? Like, Delhi, Bombay, or, syllables. So they are giving spondy words. They will determine speech threshold. And speech discrimination will mean any speech above the threshold. So therefore, both of them are important. And if there is a significant loss of speech discrimination, that this again points towards a sensory neural hearing loss, right? Now, in the sensory neural hearing loss, you can have two types of sensory neural hearing loss. Either you can have a cochlear or a retrocochlear hearing loss. And that you do by two things. One is that if there is any recruitment phenomena. What is recruitment? Recruitment means that in some frequencies, there will be a very high sound which the person can perceive. So suppose you go on increasing the TV, then there will be some frequencies where there will be a sudden high sound which can be seen. That is one phenomenon of recruitment. That is number one. And the second is decay, tone decay, meaning if you give continuous sound, then the person, there will be decaying of tone. So a cochlear will have these two, whereas a retrocochlear will not have these two. So this is how you differentiate between them. Another thing you said was drugs. So you say you gave a number of drugs which you said were responsible for, which were not responsible for the hearing loss. So if a person has hearing loss because Rishabh, I can't see your face because you are yeah, this is better. So now if you are giving drugs, what kind of hearing loss do you get? And when the pathology is something else, then what kind of hearing loss do you get? We can't hear you.
No, he's muted. He's muted. He's muted.
Sir, drugs like aminoglycosides and streptomycins are known to cause sensory neural hearing loss because they act on the receptors, the organ of Corti, and they damage the receptors, basically.
Yeah, but you must remember that as soon as you're talking about drugs, you're talking about bilateral hearing loss. You understand? So a unilateral hearing loss is very rarely because of drugs. Usually drugs will cause bilateral hearing loss and not unilateral hearing loss, right? So that's one thing which I thought I needed to tell you. So one was this. Then the third thing is, you said that this patient has cerebellar signs because there is no worsening in dark or in uneven surfaces. So I want to ask you something. What are the ways in which a person maintains posture, and do you think a person with a cerebellar signs will not worsen in the dark? We can't hear you. We can't hear you.
So the proprioceptive receptors, which help in the gait and the stance of the patient, because the proprioceptive receptors are intact for this patient, on the history which we could judge that the proprioceptive receptors were not affected, because he's saying that he's not affected by dark because the sensory stimuli is not helping. It is not the sensory stimuli which is affected during the walk, or the proprioceptive which helps during the uneven surfaces.
No, you see, the important thing is that if there is a person who has cerebellar signs, he's still stable by using vision, and he's still stable by using his vestibular system. But what happens is that in the dark, there is no vision. So what happens is he will also become unsteady. So it is very difficult to differentiate a person in the dark, and even a person with cerebellar signs will have unsteadiness on uneven surfaces and in the dark. You understand? So you cannot really differentiate between the two, because he is going to become unstable as soon as one of his stimulations of steadying, which is vision, will be compromised. You understand? You cannot really differentiate between them based on that.
No, what Dr. Sanjay, just one, I mean, the common mistake, what Dr. Bihari said, this is a common mistake. This dark, everything will get worse. But when somebody is not in the dark, the posterior column, the patient, that is the differentiation, everything will get bad in the dark. Whereas in the posterior column, people will be normal in the normal surroundings. Whereas in the daylight, whereas the cerebellum will also be abnormal in daylight. That's the difference. It's not that dark cerebellum will not get worse. All cerebellar signs will get worse. Everything you are putting in discomfort because another sensory stimulus is lost. So
Yes.
the other way around is correct. The patient who has a posterior column dysfunction, he will be all right in daylight, will get, or if whatever it is, it will get worse in the dark. Cerebellar also will get worse in the dark, but cerebellar also will be bad in the daylight, whereas posterior column may not be as bad in the daylight.
So
That's the difference.
Yeah. So,
please go ahead, Sanjay, go ahead.
Yeah. The next is, you said reduce sensation on the face, right? But you have to be, there are several ways in which sensations may be reduced because of fifth nerve involvement. So what are the ways in which sensations can be reduced?
So can you repeat the question once?
You just gave a broad statement that the patient is complaining of reduced sensations. But what are the ways in which sensations can be reduced on the face?
Sir, the only general comment he made was reduced sensation. He did not comment about pain or temperature or anything regarding.
So what are the leading questions which you could have asked him? What are the leading questions which you could have asked him?
So we could have asked him leading questions like whether he has any injury marks while shaving.
No. In the sense, say, distribution of pain or sensation. So you have to be more specific. You have to understand that you have to say 2-3 things. You have to qualify with this with a few things. One is, what is the dermatomal distribution of the sensory loss? So is it occurring all over the face, or it is occurring in upper part of the face or lower part of the face? You have to give leading questions to ask this question. The second very important thing, yeah.
So on the questions which I asked, he said there was a right-sided hemifacial sensory loss.
Yeah.
Not comment progression of the loss, whether it was from up to down or down to up, or whether it included only the middle segment of the face. Yeah. So that is how we commented on it. So,
yeah. So when would you say that a person has lost the upper segment? When would you say middle segment? And when would you say is the lower segment? What is the dividing line?
Sir, the dividing line is from the vertex till the angle of lateral canthus. That is the V1 segment of innervation.
What
From
about the upper lid? What is the upper lid? Upper lid, lower lid, nose.
So upper lid, lower lid, and the nose. The middle of the nose is by V1. The lateral of the nose and the till the angle of the mouth is V2. And below the angle of mouth, from the angle of below the angle of mouth, in front of the tragus, that entire region qualifies for V3.
No, one
lower
small
lead.
Sorry.
Lower lead.
Sorry, sir.
Lower lead, you said what?
So, so lower lid is by V2 and the outer of the nose is by V2.
Yeah, yeah.
The middle of the
You
nose
said
and the upper
V1.
lid is by
Yeah, you said lower lead
Sorry.
V1. Yeah.
So the dividing line in the eye is the cornea. So the middle of the cornea, the upper part of the cornea will be supplied by pain fibers from the upper part, and the lower part of the cornea will be by V2. And one small thing that you must always remember is that the angle of the mandible here, this is C2 dermatome. You understand?
C2.
So if you touch here, then this is not V3. This is C2.
Yes.
You understand?
Yes.
The angle of the mandible
Yes.
represents C2. It does not represent
C2.
V3. Yeah, so that is an important thing.
Sanjay, I just want to comment one thing. The very common problem with patients who have a sensory disturbance is the redness of the eyes. They complain that they become red, the eye, especially after taking a bath, soap going inside, going outside, which is a very, very common symptoms because the V1 gets involved. So I think you have to ask some leading questions also, and that's important, I think.
Yeah. So
Go
one,
ahead.
I would like to kind of add to that. I'd like to add to what Professor Mishra said, that if there is redness of the eye, you have to ask two questions. Is the redness of the eye associated with pain, or is the redness of the eye not associated with pain and lacrimation? Are you understanding? So this would mean that, you know, if the fifth nerve is involved, there will be no pain, but there will be redness. And if the seventh nerve is involved, then there will be pain and redness, but the you know, that will be the differentiating feature, right? So if redness will be there without pain, or redness will be there with pain. That is a very important part of it. So this is also a way to differentiate between them. And of course, this is another thing. Then
Sanjay,
you,
one aspect about hearing, I think. See the let me see his face. Yeah. So the one of the things when you finish your history, you have to tell the current patient's disability. What is the current problem? And you said he is not working for a year. Why is he not working? Is it because of his illness? What is the progress of the disease? How far it is progressing? Is it initially what was like that and now it is same? And the progress has remained same through last 1 year or so? And every history has to finish with the current status, okay, and what he started with and what is the current status. You did not summarize the current status. I mean, you said okay that, and what was, is his daily life getting affected, is he, has his work getting affected? And first, when you started the history, the most important thing you said, the history given by him and his wife, is it reliable? That's very, very important. If it's not reliable, I mean, we can't give too much of importance to the history. So the part you started, that's good. There's handedness and all that, but also reliability should be said. And you finish the history with the current disability and what is it's affecting his daily life or not. And about hearing, the one very simple thing you check whether he can take. I don't know whether I don't know whether if I missed it. I don't think you said whether he's taking telephone or not. You know, it's a very simple thing. This is a disability because the patient, whether you test it after, that's fine. Now, many patients who have hearing deficit still can communicate on telephone and they don't realize, even when we see that even the BERA is negative, they're still talking on telephone. Okay. And it's very important whether patient can or cannot communicate on the telephone because today the world is digital world. You see that, right? So that I think you should have also told when you're telling the history. Sanjay, please go ahead.
yeah, so it is the extent of hearing, it is the directionality of hearing, it is the speech discrimination, and finally, whether there is sensory neural hearing. So sensory neural hearing will be based on a high pitch failure to discriminate a high pitch tone and difficulty in hearing in the presence of a surrounding noise. You know, these are very characteristic feature of sensory neural hearing loss, right? So these are something. Another very important thing is when you came to seventh nerve, you said that there is you know, facial, a little facial deviation. But is it upper motor neuron facial does this patient have, or a lower motor neuron this patient has? Can you differentiate only on the basis of history?
So on
Just
the
what
basis of
history you
my
have, can you differentiate between upper motor neuron and lower motor neuron facial? Just on the basis of the history that you have.
So on the history, whatever I got was the wife had just seen a mild facial asymmetry by saying that his angle of mouth was deviated to left. Apart from that, he did not have any other complaints of complete hemifacial weakness. So on that basis, we could say that probably it has to be a lower motor neuron.
No. You see, there's no difficulty in eye closing. There is nothing related to the forehead. So how did you come to the conclusion it is lower motor? There's a very simple technical way. If a patient has taste involvement, it is lower motor neuron. A taste involvement of the anterior 1/3 of the tongue cannot be upper motor neuron. You understand? So taste involvement definitely is a sign of low motor neuron involvement, right? So you can further qualify this that there is taste involvement. The other thing which you should have asked a leading question when this patient talked about fifth nerve involvement was hollowing of the cavity. So temporalis cavity is hollow or not. That should have been said. And also the other very important thing is that malocclusion. So many of these people who have fifth nerve involvement, especially the motor part of the fifth nerve, will have mandibular malocclusion. So you will say that they will have difficulty in chewing from one side. You understand? So these are some leading questions which you can ask, and then you know whether motor fifth is actually involved, because it's usually going to be very subtle and you won't be able to pick up. Then the other thing was, you said the headache was suboccipital and frontal. So why did this person have a suboccipital and a frontal headache? Yes?
Sir, the headache was mainly occipitofrontal rather than suboccipital, and his complaint of headache I felt was not related with the disease process itself. It was mainly because of the ophthalmic change in the numbers of his glasses because of his myopia.
No, occipital. Where occipital? Where was the headache? Where exactly was he getting pain?
Sir, basically it was from in the occipital headache, which was it was an occipitofrontal headache. It was a hollow.
No, was there a laterality? Was there a laterality to the headache? Was there any particular side he was getting headache, or both sides?
No, sir, both sides. It was both sides.
So it was not unilateral, because you said unilateral. I thought you said unilateral. It was only on one side, right? So supposing, okay, if there is a suboccipital headache, what is the cause of suboccipital headache?
Say the suboccipital headache could be due to the stretch of the dura because of the SOL growing inside, along with the finding that we have seen that there is involvement of the trigeminal nerve, which also supplies the dura of the brain.
So dura, which part of the dura? Trigeminal nerve does it supply posterior fossa dura, or it supplies supratentorial dura?
It supplies the supratentorial dura, sir.
So the posterior fossa dura and the petrous dura will be supplied by the lower cranial nerve. So 9, 10, 10, which also has a referred pain, can be in the suboccipital region there because of the stretching of the dura there, right? And the tentorium stretching can result in frontal headache. You understand? So so this is this you can.
And always, whenever there is a posterior fossa mass and the patient has suboccipital headache, not occipital, suboccipital headache, that could be a danger sign. That could be a warning sign. So we have to be careful about it, because that could be a sign of herniation. An early herniation, if the patient is going down in the foramen magnum, the tumor is going down. So one has to be, so never ever ignore a sign, a patient who has history of a suboccipital headache and you have a suspicion of a posterior fossa mass, that could be a warning sign for an early intervention. Yeah.
One small thing with suboccipital headache, if there is impending herniation, what else will the patient have?
So can you repeat the question once?
If there is impending tonsillar herniation with suboccipital headache, what else could the patient have?
So since we are talking about the lower cranial nerves, the patient can have change in voice.
Neck stiffness. So suboccipital headache with neck stiffness, you have to immediately do something. You know, if there is hydrocephalus, you have to do a shunt or an external ventricular drain. If there is only a tumor there, large tumor, you need to remove it. Right?
And some direct questions you ask that, whether on straining or a patient has coughing, he has a cough syncope or a cough, he gets, pain going down the neck, the stiffness Dr. Bihari already told about. And so any straining, coughing increases the suboccipital headache, again is a warning sign. Any Chiari also can have the similar symptoms. So it's basically a tonsil in the foramen magnum will give a similar symptom.
Now, one small thing, if there is no sensory involvement and only pain and temperature involvement with fifth nerve, then what will be the distribution of the sensory loss? And how will you determine it? Sorry? Sorry?
So can you repeat the question once?
If there is pain and temperature, you did not test for it, but if you were testing for it and there is pain and temperature loss, then in the distribution of fifth nerve, what is the distribution of pain and temperature loss?
So there could be involvement of the spinal nucleus and the mesencephalic nucleus when we are talking about the pain and the temperature loss for the patient.
So how will it manifest on the face?
So it has to manifest as an onion skin or a balaclava distribution. It's basically a circular pattern in which there will be a loss. So the rostral spinal nucleus is mainly which covers the middle of the face, whereas the caudal spinal nucleus will be covering the lateralmost part of the face. So it will be in an onion peel appearance. And secondly, we need to check is for the perioral sensation when we are checking for the dermatomal distribution in the for the loss of sensations.
Okay, good. Now, you're in your differential diagnosis. Your first differential diagnosis was a vestibular schwannoma. Your second differential diagnosis was an meningioma. And your third differential diagnosis was an abscess or a tuberculoma, you said?
Yes, sir.
No, but
Yes.
is there another tumor which is more common than an abscess?
So arachnoid cyst or an
Arachnoid cyst very early.
so I have
And dermoid, right?
Okay, just can I just when you give a differential diagnosis, the things to see is number one, your first diagnosis is your vestibular schwannoma. You are muted again. Who is presenting? Is Ankit Agarwal presenting or Rishabh is presenting? Who is your name is coming? Ankit. No, you are muted. You are muted.
Rishabh is presenting, sir.
Rishabh. Okay, your
Sir,
name is
Rishabh
coming
is
as
presenting.
Ankit. Yeah, is coming as Ankit there. Okay, fine. So now any time you give a diagnosis, the rule is first points in favor of that diagnosis and point against that diagnosis. Okay, so if you go along with that, what are your first diagnosis? Vestibular schwannoma. What are the points in favor and what are the points, if any, against the vestibular schwannoma? Can you tell? There is one of the young neurosurgeons said, why straight
my
CP
points
angle?
in favor of vestibular schwannoma would be the loss of hearing.
No, your voice is breaking. Ankit, your voice is, sorry, Rishabh, your voice is breaking. You have unstable, yeah. Internet is unstable, yours. I think I can't hear. Sanjay, can you hear anything? You're muted, Sanjay. You're muted.
No, I cannot hear it. I cannot hear him. So till Ankit, can you join back again, Ankit? So I think we can discuss ourselves their differential diagnosis since everybody else is hearing. So when would you say that a patient has a vestibular schwannoma and will not have a meningioma or an epidermoid? When would you say that clinically, historically? So I'm asking you, Dr. Mishra, because
okay.
Ankit is not answering. So Ankit
There
is
is a
not
guy. There is a young neurosurgeon who is saying, "Can I volunteer?" Let him volunteer.
Sure,
No?
sure. Oh, yeah, please.
Hello.
Yeah, he's come
he's
back.
Yeah, he's back.
Yeah, I'm extremely sorry, sir. Actually, my network went off.
Yeah. Now you are with Rishabh Chedda. Yeah, go ahead. So points
Yes,
in
sir.
favor of a vestibular schwannoma. That's your first diagnosis.
So my first diagnosis of vestibular schwannoma, because one was the age of the patient, 62-year-old patient presenting with a hearing loss. Secondly, the hearing loss was more of a retrocochlear hearing loss, sensory neural hearing loss from his history, because he had to hear, he was better able to understand hearing, people hearing in a quiet environment. And secondly, he was
There is a good question from a young neurosurgeon. Why age? Age is not. That's not important. That's correct. That should not be the first point of in favor of a vestibular schwannoma. That's correct. Somebody pointed out that one of the young neurosurgeon has pointed why age, and that's the correct thing. The age is not a factor which should come at the first point in favor of your diagnosis. Why was your diagnosis the first diagnosis vestibular schwannoma? 1, 2, 3, 4, 5.
So one was because of the involvement of the vestibular nerve. It involved his hearing first, and second,
vestibular nerve caused hearing loss.
Cochlear nerve, sir. Cochlear nerve.
No, just listen. Patient had, what are symptoms? Patient has hearing loss, is it? Unilateral, gradual, progressive hearing loss. Okay?
Yes, sir.
Without any predisposing factors which could cause that, like you gave no history of infection, no history of drug injection. I don't think you gave that history of meningitis or not, that you should have told. One of the common causes in India, in our developing countries, is deafness, but usually bilateral again. But they can have also unilateral deafness. So infection, there is no history of infection, trauma, ear discharge in a person of any age group, mostly in the fourth and sixth decade, up to 35 to 65, 40, 55. This is the common age group. Younger people are neurofibromatosis. Elderly group patients are less commonly they present with like this. More common is this age group. So any patient who has adult unilateral progressive hearing loss is diagnosed acoustic neuroma or vestibular schwannoma till proved otherwise. That's the only way you may not miss it. Because many patients in India get away with a progressive hearing loss and never get tested, never get an MRI till they get a giant tumor. And similar to maybe your patient has other symptoms, other substrates are involved. It's not only the eighth cranial nerve which is involved. Where did you go, Rishabh? He has disappeared.
No, Hello?
There you are.
Yeah.
Can you hear Dr. Chedda?
Yeah. Can you hear me?
We can hear somebody, but we can't see your face. I don't know who is talking.
Is it better, sir? Right now?
No, your face is not seen. We can hear something. Somebody is muted. Rishabh is muted. I don't know who is speaking. Yeah, now you are there. Yes. Okay.
Yes.
So one is hearing deficit, which is unilateral progressive. Okay. And then what else? Next.
So secondly was involvement of the neighboring nerves, that trigeminal.
No. He had tinnitus, no?
Yeah, no, sir, he did not have tinnitus.
Oh, he did not have tinnitus. Okay, right. All right. Okay. Okay. Go ahead.
So second point in the favor of it was because of the involvement of the neighboring nerve, the fifth nerve and the seventh nerve. Fifth nerve because the involvement was earlier compared to the facial nerve. And he did not have any irritative symptoms, which are generally seen in the epidermoids.
And
sir, it was a unilateral loss.
No, that we told. Unilateral, first is unilateral. It has to be first unilateral. This is the commonest lesion in latatus. So it is in the CP angle. you have according to your history symptoms suggestive of a eighth nerve involvement. You have a fifth nerve involvement, a seventh nerve involvement, a cerebellar dysfunction, and the so it is in the CP angle. Some
Yes,
young
sir.
neurosurgeon asked why CP angle, why not posterior fossa? Because it's a constellation of symptoms in a very close area. So it is CP angle tumor. There's no question. And the commonest CP angle tumor is vestibular sonoma. Okay, so that is the common that instead of telling the other things irritative and all that is not necessary, not important. The first thing, this is the commonest one. Okay. Now there is a doctor who is a young neurosurgeon asks, can a cerebellar something? I could not see what is the question. Somebody can take that question. I think, can a cerebellar region near the CP angle give some symptoms? Of course, everything can happen. But the common things common. There is a young neurosurgeon asks, can a cerebellar? Yes. A tumor, any brain tumor can also have false localizing signs. But that's not the point. The point is what is common. Common things common. What you see when a patient come to your clinic, first impression comes to your mind, that should be the first diagnosis. It may not turn out to be true. If your reasoning is correct and your diagnosis is wrong, in the exam you get full marks. Professor Bihari will pass you. But if your reasoning is wrong and your diagnosis is correct because your colleague gave you the diagnosis, you will fail. Okay? Go ahead. Yeah, Dr. Bihari will take over now.
Yeah.
Yeah.
Now, so clinically, Professor Mishra told you when you would, because the commonest lesion, it's a vestibular schwannoma, unless proved otherwise, if there is hearing deficit, right? When would you think that it is a meningioma? When would you think it is definitely a meningioma and not vestibular schwannoma clinically?
No, muted. You are muted. You are muted, Sirisha.
So meningiomas mainly would present with pressure symptoms rather than involvement, and meningiomas would initially present with 7 nerve symptoms rather than hearing loss.
So if there is a CP angle syndrome without eighth nerve involvement and progressive symptoms, mass effect, and therefore it could be a meningioma. It could be any other thing, but meningioma is the
But
second.
meningioma is the always incidence also keep in mind. Meningioma is the next common CP angle mass. Okay. After, if you see the incidence of the CP angle masses, the first one is vestibular sonoma, second one is meningioma. And important thing, as you said, if there is a no hearing loss and the patient has a CP angle syndrome, but hearing is preserved or is a late manifestation, then meningioma comes up high in the order. Yeah.
Then when would you think that it could also be an epidermoid? Epidermoid. What are the features which would suggest that it is likely to be an epidermoid?
So epidermoid would have more of an irritative symptom, especially like
First
presenting
thing
with
first.
meningitis.
First thing first. Long history. First things first. It's a long history. So that's very important. Okay. Duration of symptoms, how much he has. And then what you said. Yes, go ahead.
And definitely no race pressure. So usually
No race pressure.
until it is, so multiple cranial nerves involvement without race pressure. And that's a very important aspect. What are the other? You said abscess, but abscess and tubercular abscess. So don't use abscess and tubercular abscess synonymously. I'll tell you why. Because a tuberculous abscess is an abscess with acid-fast bacilli, and a tuberculoma has the characteristic granuloma of tuberculosis. You understand? So don't use them
And
also.
then this abscess, you give a differential diagnosis of abscess. Abscess is not a CP angle lesion, it's a parenchymal lesion. It's a cerebellar mass. Usually, if you have an abscess, which you probably see in, your hospital, you may be still seeing it. In India, we used to see, we don't see it in my hospital anymore, but I'm sure you must be in your setups, you may be seeing it. But it's a parenchymal lesion. They do not come with this history of eighth nerve, seventh nerve, progressive. No. They are much more acute symptoms, much shorter history, and usually associated with some kind of other incriminating history, like maybe ear discharge. And there is a cerebellar mass. This is not a CP angle mass. Abscess is not a CP angle mass. Whereas tuberculoma or tubercular abscess could be a CP angle. That could be extraaxial. But pure pyogenic abscess, rarely, if ever, unless it is burst, it's a parenchymal lesion. Okay. There are much more, 10 differential diagnoses you should be able to tell before you reach abscess, which is a very rare thing to happen in CP angle.
What are the other differential diagnoses that you can think of? Rishabh.
Other differential diagnosis I could think of would be an metastatic lesion in the
listen. There should be a system. There should be a system so that you don't forget things. Okay. So when you are going for a differential diagnosis, lesions of that area, from that area pathology. So what are the structures there in the CP angle and in around the CP angle? Extra axial lesions should come first. Number one. Number two, then the lesions in area closer to the CP angle. Okay. Again, extra axial. Then the lesion parenchymal intraaxial lesion presenting as an extraaxial lesion, a CP angle. Then bony lesion presenting an intraaxial lesion. Then distant lesion presenting as intraaxial lesion. And again, each one should have a classification of congenital, inflammatory, neoplastic, vascular, like that. So you'll not miss it. You understand? At each point, you should have this classification in mind. You don't have to tell it. But start off with a congenital, inflammatory, neoplastic, vascular, degenerative, or infective, whatever. You have that order. So when the examiner asks you, you go in that order. So person knows, okay, this boy is thinking. You understand? And always any part of the brain or CNS, the lesion which is in that area, CP angle, comes first, then the adjacent, then the distant. And the adjacent will be extraaxial, intraaxial, bony, extracranial, and parenchymal lesions which is coming into that area. Okay? So then you will not miss anything. And go ahead, try again. No, muted again.
The lesions which would be included in that region, the extraaxial lesions would be depending on the neurovascular bundles, which would include the vessels like pica or pica, which can have an aneurysm.
No. Mass first, and the unusual. First, come to the common things.
So what you have such a large amount of field involvement. You have facial sensation involvement, such a large amount. So what other tumor would you think of, which is at the petrous apex, which can involve facial? Yeah.
So we can think of a petrous bone meningioma.
So more than
one is meningioma. Then
fifth nerve what? Another thing.
So trigeminal schwannoma.
So that is a very differential.
Tell that, no, that is, you have already got involvement there. And then what else can have the 5th, 7th, 8th involvement? What other tumor? First go to tumor. This is a mass lesion. It has produced like a mass. So first tell the mass lesions extraaxial in that area. So you told vestibular schwannoma, meningioma, trigeminal schwannoma, then what?
So others, it can include lesion in the internal ear, which can be a cholesteatoma.
Okay. Unusual, very unusual. Cholesteatoma usually present in the petrous apex as a middle fossa lesion. They don't usually present as a CP angle. Okay, so their center of lesion is in the petrous apex and usually as a petrous apex mass or a middle fossa mass. Okay. And then what are these CP angle mass? What are the things will produce as CP angle mass?
So others could be a dermoid.
Again, you can go on the. What about other mass lesions, big mass lesions which produce mass effect?
So what are the structures? So what are the structures at the CP angle? You have several structures at the cerebellopontine. You have bone, you have vessel, you have dura. Okay, you have neuroaxis, right? So based on that, you will have different lesions. So now one important is bony lesions. So what are the bony lesions? Large bony lesions which can occur in CP angle. You can have lesions which can come from the fourth ventricle into the CP angle. So what are the bony lesions?
Extraaxial lesion, you have a glomus there, you have a lower cranial schwannoma. The cranial nerves are in and around 2 millimeter difference between 8th and 9th. Okay, so 9th cranial nerve schwannoma can there, he may not have any symptoms. Please understand, he may not have any lower cranial nerve symptoms, can produce a mass lesion in CP angle. Eighth nerve is a very, very sensitive nerve. So they present with that, in spite of the fact that it's not eighth nerve sarcoma. So from other things which you are talking, they're much later they will come. Cholesteatoma will come much later. Dermoid does not happen there. It's an epidermoid which happens there. One of the young neurosurgeons pointed out dermoid usually is a midline lesion, though it can go there. So glomus, okay, lower cranial schwannoma. And then Dr. Bihari is asking one important question. What are the bony lesions there which is coming there? Which happens, which presents.
So the bony lesions would include the chordomas.
Chondrosarcoma is more common. Chordoma is usually a midline lesion, though it's a pathological differentiation, but it's a chondrosarcoma which presents laterally. Chordoma is usually a midline lesion, but of course they can also have lateral extension. So chordoma or chondrosarcoma. And what else? The another Dr. Bihari asked, what are the structures in there?
The structures
Have
there,
you heard of an
would include the
endolymphatic
fetus.
sac? Have you heard of an endolymphatic sac there? Endolymphatic sac tumor. Okay, you cannot distinguish. It's very close to the vestibular nerve. You cannot differentiate on anything, even on imaging sometimes, till you open up an endolymphatic sac tumor, much less common than a vestibular schwannoma. Okay? Again, then you can have your classification. You started with, say, for example, congenital vascular inflammatory, and always, of course, metastasis you said, which comes a little later. I think there is a announcement that you are stopping in 30 minutes, Sanjay. I think you have to move on for findings. Sanjay, you are muted. Sanjay, there is some notice came that you are closing in 30 minutes.
So are we closing in 30 minutes? Yeah. Are we?
That's what they said. It's written there.
No, sir. We can ask John if we can continue more than this.
Okay, I'm sorry, we have another conference. Yeah, hi, we have another conference after, so we have to close in 30 minutes, unfortunately.
So you go into the examination findings, I think that then we'll part of it. Let's finish in 15 minutes examination and then we can have some discussion about management.
Sure.
Okay. But for all young neurosurgeons, the diagnosis very, very uncommonly changes after the proper history is taken and a reliable history is there. Most 90% plus times your diagnosis is based on history. There's only some add-ons in the examinations. Very, very less commonly you get extra things from examination. But anyway, go ahead, tell the positive, go because you don't have time. Tell the relevant positive and relevant negative findings.
Yes. Is my screen visible, sir?
Yeah, there is something you are on a boat. If that is your screen.
Yes, that's it.
Oh, no. Yeah. Okay. Yeah, now he's got it. Yeah, go ahead.
Yes. So my patient was an averagely built, averagely nourished patient with a normal vital examination.
No. Hello. What did I say?
Yes, sir.
You don't have time. So the examiner doesn't have time. So you tell the positive findings and see, always listen to the examiner's question. You cannot go on to whatever way you have prepared in the exam. Now there is no time. So you have to tell positive findings and relevant negative findings.
So my positive findings would include my patient had he had a nystagmus in bilateral lateral gazes with a fast component to the left side and a slow component to the right side. There was absent corneal direct and consensual corneal reflex on the right side, while the corneal reflex on the left was normal. There was decreased sensation in the V1, V2, V3 segment on the right side of the face. With an absent jaw jerk, but on motor examination of the trigeminal nerve, there was normal bulk and power of the muscles of mastication. On facial nerve examination, we saw that there was taste sensation affected in the right anterior 2/3 of the tongue, while and there was absent sensation on the posterior most middle part of the right pinna behind, as in the posterior most part. As well as there was motor weakness in the right buccinator and deviation of the angle of mouth to the left. There was sparing of the frontalis muscle and he was able to close his eyes properly. On eighth nerve examination, he had a negative, false negative release test on the right. Was more than the air conduction. The air in the left ear, and the Weber's was lateralized to the left ear. On vestibulospinal examination, the pass pointing was towards the right, and on Romberg's test, the sway was towards the right. He had a normal 9th, 10th, and 11th cranial nerves with a normal 12th cranial nerve. On cerebellar examination, he had intention tremors present on the right side. He had an affected finger to nose test on the right with an affected heel, knee, shin test on the right. He was not able to alternate pronate and supinate quickly on the right side as compared to the left side. And on tandem gait, there was a sway to the right. However, he did not have any evidence of titubations. The rest of my general examination was within normal limits, sir. So to summarize the case, this was
No. Just one second. Did you comment on the fundus?
Yes, sir. I've actually written. I've forgotten to comment about the fundus.
What did I tell you? The relevant
Yes,
negative findings. The relevant
Yes,
negative finding fundus is always has to be told. Doesn't matter whatever it is. Okay.
Okay, sir.
So
Yes, sir.
it doesn't matter
Yes, sir.
what case you are doing. Even in a spine, you have to tell fundus. So that is important. And then some other relevant negative finding in this particular case, which you did not general examination within normal limits will not do. So what are the relevant negative findings you must mention in this?
Sir, I should have looked for. I should have spoken about the neurocutaneous markers.
Yeah, so you should have told neurocutaneous markers, swellings in the body, and that's very important. You should have told that. So that is the relevant negative findings. Okay.
Yes, sir.
Okay,
Yes,
Dr. Bihari, if there has any questions, you can just point out before you go on.
Yeah. So there were a few. I had a few problems. One of them you said was. One of them was that you said, can you just remove the screen, please, so that I can see you? So there were a few things. First of all, you said that this patient had significant seventh nerve involvement. The taste was involved, and there is, there was a loss of angulation of the mouth and drooping and all that. Although the eye closure was adequate. And yet, when you did your corneal examination, you did not get any findings of seventh nerve involvement. So what were the findings of seventh nerve involvement that you should have got in this case? I mean, I was anticipating those findings. So what were the...
So actually, I should have talked about the nasolabial folds, the asymmetry in the nasolabial folds, the ability to evert his lips.
No, you're missing my question. I think your corneal reflex elicitation is not correct, because you said that on eliciting on one side, the opposite side you're not seeing, but it is not correct. You have to do both sides. You understand? You have to say equilateral side, and you have to say consensual side also. Are you understanding? Corneal is always both sides. So what will you get on consensual reflex on the side of examination?
So on the side of, actually, the patient had an abnormal direct as well as in consensual corneal reflex on the right, and on the left, the direct and the consensual reflexes were normal.
Yeah. So therefore, in that sense, I mean, when you tested from the consensual side, then probably I would say that your reflex on the side of involvement should not have been there had there been significant seventh nerve involvement. Because there is significant seventh nerve involvement there, taste is gone, and you have. So I think you need to look at this again. I think there is some mistake here. Are you understanding? So on the ipsilateral side, both direct and consensual will be gone, and on the contralateral side, the consensual will be gone, because both fifth and seventh are involved. That is something which I think there is some problem. You need to recheck again. The second is you said something about nystagmus, and nystagmus you said on one side there's folds, and that's not how nystagmus is described. So how is nystagmus described? Nystagmus, first you say what is the position, what is the nystagmus in primary gaze? That is the first thing that you say. Are you understanding? Then number two, you say is this a gaze evoked nystagmus? What does gaze evoked nystagmus mean? The direction of nystagmus will change. So the direction of nystagmus, the nystagmus is usually based on the slow component, but it is named after the fast component. That means the corrective phase. So what happens is if you had taken the eyes to the right side, then that's a coarse nystagmus, that's a pursuit movement. And the corrective phase in the center would have been a fast component. So, end-case nystagmus, which this patient must be having, will actually mean that there is a coarse nystagmus towards the right side and a corrective phase. Are you understanding? And on the left, on the left side, there is a fine nystagmus with a corrective phase. Do you understand? So first is primary gaze. The second is, this is a gaze evoked nystagmus, which means it changes its direction based on the gaze, which means when you're doing a right-sided nystagmus, then when the corrective phase in the center, that is the side of the nystagmus. So it is changing its direction in the direction of gaze. Do you understand? Did you understand? That's a gaze evoked nystagmus. The third thing is you have to talk about coarser on one side and finer on the other side. That's a very important point. The fourth point is whether it is a grade 1 nystagmus or a grade 2 nystagmus or a grade 3 nystagmus. Grade 1 will be, say, in the center. Grade 2 will be on the ipsilateral side, center, and contralateral side nystagmus. So you have to classify nystagmus based on these particular features. And then this is most likely a gaze evoked nystagmus with coarser component on the right side. Do you understand? And a gaze evoked nystagmus changes its direction. That's one thing. The third problem which I had with your examination was when you said, that's a very interesting thing. You said that the bone conduction on the right side is better than air conduction. We agreed that this, you said it's a false Renes. On the left side, the air conduction is better than bone conduction. But your Weber's is lateralized to the left ear, right? That's the second thing. But your absolute bone conduction is normal as compared to the examiner. That is not possible. You understand? And why is this not possible? This examination is wrong. And I'll tell you why it is wrong. Because the fact that this patient has a false Rene is because on the right side, there is profound sensory neural loss. And because of this profound sensory neural loss, the bone conduction is being transmitted to the left side. And that is why the patient is hearing from the left side. Did you understand? So therefore, when you're doing an absolute bone conduction test, which is actually measuring the sensory neural hearing loss of the patient as compared to the examiner, it cannot be normal. That means there has to be a profound sensory neural loss of the patient as compared to you as an examiner. Is it clear? Did you get it? That's a very important thing. And then, of course, I mean, these are three important things which I thought you needed to look at, when you were doing the examination.
What are the sensory components of seventh nerve? You are muted, muted. You are muted.
So the sensory components of the seventh nerve would include the taste sensation and the external auditory meatus, the posterior 1/3 of the external auditory meatus.
But
and
you did not tell that.
Hello.
Yeah. But you did not talk about the external auditory canal. You didn't mention anything about. So that's it. If it was not there, it's a relevant negative finding. It has to be told. Yeah. Okay. I think Sanjay, you have to move on because they are going to finish time, and you go on to the management. You have 15 minutes left.
Okay.
Go on.
So,
go. What are you going to do with the patient? So your diagnosis has it changed? Your diagnosis has it changed after your Dr. Bihari pointed out one of the main was your blunder was the hearing this thing, and that would be classified as a blunder. Rest would be okay. That go ahead, but the hearing was not acceptable. You understand that? Because that would go as a very, very strong mistake. But again, anyway, so after that, what is your diagnosis?
So my diagnosis would still remain the same. It would be a CP angle SOL, most likely to be the vestibular schwannoma because of the correlating findings, as well as the most common SOL being in the region being vestibular schwannoma.
Okay, now so go ahead with how will you manage this patient, because you don't have time for more.
So for this case, I would initially like to have a blood workup done. Secondly, the most important thing would be to assess the loss in the decibel that by pure tone audiometry and by brainstem evoked responses. I like to check for the auditory if the patient can have a salvageable hearing or not.
No,
Thirdly,
just
I would like,
one second. So what are the neuroaudiological evaluation you did, and what were the findings expected?
so the neuroaudiological evaluation which we can have is a pure tone audiometry, which will have a profound sensory neural hearing loss on the right side. For this patient, the hearing loss was 127 decibels.
No, Joe, which is what?
Which
Which is sensory neural is what? The pure tone audiometry you did. So sensory neural hearing loss is in what decibel loss and in what frequency? In what frequency they usually lose?
So the frequency used for this patient was from 20 to 2000. The decibel loss was 127 decibels.
120 decibel only he could hear.
Yes, sir.
And where in a lower frequency was lost, or higher frequency is lost, or all along it was lost?
Sir, I have the image if you allow me to show it.
No image. You tell.
So he had all the high frequency loss.
No.
Anything all above 500, there was a significant loss in the hearing.
No, so Rishabh,
Excuse me, gentlemen.
normally
Excuse me, gentlemen. 15 minutes, okay?
So when you do a pure tone audiometry, there are two things you look at. One is the extent of loss. So from 0 to 20, loss is normal hearing. You understand? And a profound loss is about 80 to 90 decibels. Beyond that, it is very difficult to assess loss. So anything more than 90, you say it is profound sensory neural hearing loss. The second thing that you assess is whether it is conductive or a sensory neural or mixed type of deafness. So here you said it was clearly a sensory neural deafness because there was no airborne gap. The third thing that you assess is what is the frequency of loss. So with a vestibular schwannoma, usually it's a high frequency loss that you get. So you will get 1,000. You will get it at 1,000, 2,000, 4,000, 8,000 kilohertz. I mean hertz. That is the level at which you will get the loss, not kilo, but just hertz. So therefore, these are the three things that you have to assess on a pure tone audiometry, right? Now, with such a profound sensory neural hearing loss, if you do a BERA test, brainstem evoked response, then when the first nerve is not transmitting, then you will get a flat wave on the side of the BERA on the right side. You understand? So you might just be wasting money. Are you understanding? So you have to understand that with a significant loss, which you think is more than 90 decibel loss, doing a BERA will get you a flat line on the right side unless you go to a very high intensity. You understand? So therefore, that you will just get a flat line there. That's the second thing that you have to understand. Now, the third point is, what is the role of masking in profound sensory neural hearing loss? Because here, whenever there is a profound loss, again with bone, you can hear it on the opposite side. So you will see, so therefore you have to mask the ear, opposite ear, when you are doing an audiogram. So here also, even with an audiogram, you have to mask. So these are some of the things that you have to talk about whenever you're doing an audiogram here. Is it clear? Yeah.
What are the other neuroaudiological findings? Other than PTA, you did a pure tone audiometry. What other comments can you make? And actually, Dr. Bihari already talked about it before. No, you are muted. You are muted.
So the brainstem evoked responses.
No. Pure neuroaudiological test. Tone decay and recruitment. What happens to tone decay? What happens to recruitment?
Okay. So the speech recruitment or the speech discrimination?
No. Speech recruitment and speech discrimination are two different things. They're two different things. Discrimination is different. Recruitment is different. Recruitment is a phenomenon. Discrimination is a different thing. That's a part of the PTA.
So let me, since you don't know about it, speech discrimination and speech threshold. So speech threshold means you are giving spondy words and then asking him to discriminate. And if he's not able to do 50% of the times, then he will not be able to preserve hearing. So that is speech discrimination score. Whereas recruitment is for differentiating between cochlear and retrocochlear illness. So if there is a tone decay, meaning you are giving similar sounds and then there is a decay over a period of time, that is characteristic of a conductive hearing, I mean a cochlear hearing loss. And the other thing is that if there is in some frequency, there is a sudden step up of sound, then that is also indicative of a cochlear hearing loss. So this is recruitment and tone decay. These are characteristic features of cochlear type of hearing loss.
Recruitment is not there in retrocochlear pathology. Okay, the recruitment is positive in cochlear pathology.
Cochlear pathology. So these are characteristic of cochlear pathologies.
So nowadays, very few people do it because there are, patients come with MRI, so people forget these things. But maybe 20 years back, we used to diagnose on this total neurotological evaluation because CT scan sometimes won't pick up even. Okay, go ahead. After that neurotological, what else you'll do?
What are the radiological investigations?
Can't hear. So there are two radiological investigations which I like to do is, one would be a CT brain to check for the involvement of the cochlea and the high riding jugular bulb as well as a mastoid pneumatization. And second would be an MRI brain with contrast study, including a tractography to look for the involvement of facial nerve.
No, see, the tractography is a theoretical thing. I mean, I don't think in clinical practice anybody does tractography for a vestibular sonoma surgery. It's not necessary. It costs money. The expertise which may not be available. It's not easy. The tractography in the CP angle is not easy. Also, you need specialized centers to do it. So that's not your part of routine investigation to do it. Okay. So this is MRI brain plane and contrast is appropriate.
And one small point about tractography that I'd like to tell you about. Tractography is based on vectors. So therefore you have to assign directionality to all the vectors which are there. So what you see on a preoperative imaging in a supine position may not be the vectors that you see on prone position in the same patient. Are you understanding? So the tractography may change based on that. You can get an idea about the tracks, but it is not, you cannot extrapolate it. So this is based on directionality and changes based on position and the vectors and the colors that you assign. Are you understanding? So therefore you have to be a little careful there. Anyway, so do you have the CT and MRI? Do you have the CT and MRI? Yeah. MRI?
Yes, sir, I will be sharing. So this is my CT. Am I audible?
Yeah, you are audible.
So this is my CT, which is showing a right-sided CP angle mass, which is hypodense, isodense in nature, without any.
Listen. When you do a CT scan, you first tell what CT scan it is. Is it a plain CT? Is it a contrast CT? Is bone windows are there? First tell that before you describe the lesion.
Okay. So this is a plain CT of my patient, including the bone windows. It shows an hypo to isodense lesion in the right-sided CP angle cistern with a wherein we can see the bone windows. We can see the cochlea, the posterior and semicircular canals, and a normal jugular bulb. It's not an high-riding jugular bulb.
What else you should comment?
So there is no presence of hydrocephalus in the patient.
No. Bone window, bone, that is plain CT that you've gone beyond that. Now, CT bone window you have done. See, all those things which you told in plain CT can be seen in MRI. The only use of a CT scan in a vestibular sonoma is an added investigation is for something you said. So that is jugular bulb, which is important, and what is the disposition of some other things, and what else you should comment if you have a bone window.
Excuse me, 5 minutes, gentlemen, 5 minutes.
You have to talk about intra-aortic
So
canal.
mastoid
No.
You
So
have
when
to-
you're looking at the, let me be fast. If you're looking at the internal aortic canal, you see a difference of 2 millimeters. If you see an absolute dilatation of more than 8 millimeters, if you see a funneling, or if you see a petrous apex cutoff, then these are signs that there is involvement of the internal aortic meatus from that side. Here.
Okay,
And
show the
apart from
MRI.
that, yeah, sorry. And apart from that, please look at the pneumatization of the mastoid. See if the pneumatization extends to the suboccipital bone, the posterior suboccipital bone. These are important things when you're doing surgery, so that you can prevent CSF leak if this happens.
Right.
So
Yes.
this you need to look at. Okay, let's go to MRI.
So
Fast.
this is the
Don't
MRI
talk about
brain.
hyper. Just apart from that, apart from
So
that,
the
yeah.
first-
Just tell us.
The first image shows an T1 profile of the MRI, which is showing an hypotense lesion with an ice cream cone appearance in the
No.
CP angle system.
Hypotense MRI does not have a hypotense. It's a hypointense.
Hypointense. An hypointense lesion in the CP angle system with an with an ice cream cone appearance, which has medially it is displacing the midbrain pons, the brainstem, and laterally extending till the internal auditory canal. Posteriorly, it has a mass
Yeah, sure. Now, Rishabh, let me ask you one basic question. Why do you think it is extra-axial? Fast. Why do you think it's extra-axial?
So because there is an arachnoid plane in the region near the cerebellum, sir.
Okay, so one is arachnoid plane, the second is it is going into the internal auditory meatus. That's the second one. And the third is you see the ipsilateral dilatation of the cistern. You see the CP angle cistern on that side that is dilated. That's the third
Yes, sir.
evidence. And the fourth evidence is if there is an arachnoidal cap. I don't know, there might be an arachnoidal cap there, but I can't be very clear about it. But if there is an arachnoidal cap, that means that the parietal and the visceral layer of the arachnoid are kind of lumped together and there is CSF inside it. So all of them point towards it being an axial in location, right?
Excuse me, gentlemen, we have to wrap it up.
Okay, why is it a vestibular sonoma and not meningioma?
So because it is a hyper intense lesion on T2, and it shows a cystic area, shows an irregular
Variegated
contractile
enhancement. Variegated, variable or variegated enhancement. And what else? What are the pointers, other pointers?
Sir, a meningioma would be an hypointense lesion on T2 section, whereas vestibular schwannoma is an hyperintense lesion on the T2 profile of the MRI.
What else?
So
What
we
is
do
the
not see any.
angle? What is the attachment? Where it is extension? What is the angle between the tumor and the bone? What is the, it is going, if it is going more of the intra-aortic canal is more likely to vestibular sonoma. The angle is obtuse in meningioma, acute in acoustics, the wide attachment to the bone or the dura, dural tail enhancement, and uniform enhancement in meningiomas as opposed to in vestibular sonoma. I think that time is running out. In Sanjay, if you want to comment something, because I think he's going to close now.
Yes,
Yeah, so
thank you.
Just one. What are the surgical approaches? What are the different surgical approaches, and which one would you adopt? Since hearing preservation is not an option here, because it's more than 3
So
centimeters
the
in
hearing
size,
preservation is not a
estimation score is less, and and profound hearing loss. So cochlear nerve preservation is not an option here. Yeah.
So since the hearing, there is no chances of preservation of hearing, we would like to go by a standard retromastoid suboccipital craniotomy, which is most commonly used.
Yeah,
And,
it's Rishabh always try to use the term retrosigmoid, not retromastoid. It's usually retrosigmoid approach. There is a young neurosurgeon who is saying middle fossa. Middle fossa should not be done in large tumors, okay? And you can do translab or retrosig, but obviously retrosig is a more neurosurgical approach. I mean, there are of course pointers in favor and against, depending on your training and your expertise and your how you do along with some other colleagues. But otherwise, the thing not to do in a large tumor like is the middle fossa. You can do both translab or retrosig, but retrosig is more people do it. Why? What is the advantage of retrosig over translab? What are the advantages and disadvantages of various approaches? Just 3 approaches because you don't have time.
Last
So
question.
the major advantage of a middle fossa approach would be preservation of hearing and less injury to the facial nerve.
More injury to more middle fossa approach, more risk to facial nerve because you are working with the facial nerve you see first. So you are working beyond facial nerve. So the risk to facial nerve is higher in middle fossa than in retrosig for the same size tumor, okay? But in that middle fossa approach is appropriate only for small tumors and usually for intracanalic therapy. Both face and hearing can be preserved, but the facial nerve is at risk there, okay? And the translab, what is the advantage, disadvantage of translab?
Oh, excuse me, Doctor. We have to wrap it up. I'm sorry, I have to go. And I apologize. It's a very lively session. I hate to cut it off because we have another webcast from Nepal, and I'll show you. It's a similar one with medical students and residents, and you're all welcome to come. And I appreciate Dr. Misra and Sanjay. And Dr. Cheddar, I'm sorry, next week or the next time we have it, we'll have more time because it was a great discussion. It was great. I love the way they jump on you. It's great learning. It's a great learning experience. So, okay, we'll talk later. I have to run. Thank you, everybody.
Thank you so much. Thank you.
Thank you.
I'm